So next I'd like to introduce Dr. Chin He. Dr. He is a professor at Columbia University, a cancer population scientist, a member of the NCI CISNET modeling group since 2010, where he directs both gastric and esophageal cancer modeling. Dr. He is a world-renowned scientist and a friend of mine. If I could just share a brief anecdote about Chin. So Chin's a fun-loving guy, and I've really appreciated getting to know him through national and international meetings. We were in Santiago as part of Dr. Raquelme's conference a couple of months ago, and he calls me up on the last day of the conference, and he's like, "Rob, what are you doing tomorrow?" And I said, "Oh, I'm probably going to fly home to San Francisco." He's like, "Oh, you want to come to Brazil with me?" And I told him I couldn't. I had to go see patients. But I think that's just a great example of who Chin is. He's a fun-loving, bon vivant kind of guy, globe-trotting, and just a really fun person to get to know. Yeah. So looking forward to your talk, Dr. He.
Yeah, thanks, Rob. You know, that wasn't nearly as good as Chuha's, so I want my money back. You know, I'm not available either, but anyway. Rob, Chuha, thanks so much. And also, is Lai here? Ms. Wynn? Yeah, this has just been a fantastic conference, and to you and the rest of the team. And I'm not just saying that because of the dinner and the free Stanford merch we got. Like, we're advertising Stanford to the rest of the world, so I think we're doing you a favor. But I wanted to start with, this is I don't know if you're aware, but November is Stomach Cancer Awareness Month. And part of the reason it's November was that it's also Thanksgiving. So it's an opportunity to enjoy food that's digested in the stomach. But also, I think a lot of the senatorial lobbying came from patients with familial gastric cancer, hereditary gastric cancer. So it's also a time for families to get together. And I'm going to use this cheesy intro to say this group really has become extended family. To me, it's such a great conference. So my hat's off to Chuha and Rob for maintaining this. And as this is just a great time to get together every 2 years. So I did have some suggestions for 2 years from now. So I'll send you my comments. Okay, so I was asked to, this is my third time, I was asked to speak about the NCI CISNET Gastric Cancer Modeling Consortium, and I gave a talk two years ago, so it won't be too much. I did a little what is decision analysis in Cancer Modeling 101, so I'll kind of give you an update about where we are, what we're up to, and then also there's going to be a CISNET renewal, so kind of what we're thinking about the future in terms of the modeling. And then also talk a little bit about liquid biopsy, which is the target, the hottest thing right now in terms of early detection, including gastric cancer. So the NCI CISNET Modeling Consortium is a U01 structure and was started in 2020. And the goal is to use simulation modeling to inform and help provide evidence for things like the USPSTF and CMS Medicare for cancer control early detection. And one of the premises is, and I'll get into this, is modeling is complex and there's a lot of skepticism about modeling projections appropriately because a lot of the model inputs are based on limited data. So one of the key aspects is comparative modeling, where there's the CISNET consortium have at least 3 models, and a lot of that is for debugging, comparing, and at the end of the day, a lot of adds credibility such that when we publish, when we inform guidelines, that at least there's 3 different models. It's not one model, and hopefully a little bit less black box. So this is the spectrum of decision analysis. I'm not going to get into this, but there are very, very simple. Can you see my mouse? There are very, very simple, transparent models, like economic models are this. Some of them you can do on a napkin, and that's fine. I don't poo-poo those because there's a big benefit, which is it's transparent, and so you kind of know what you're getting. Now, the problem with building more complex is the whole, and we're seeing this in AI, right, with deep learning, is the black box phenomena. We as clinicians are very hesitant to do something that AI tells us to do, right? To let go of the steering wheel. in terms of driving as well. So very, very appropriately, there's a lot of questions about biases and the uncertainty of predictions, particularly when we're making policy, individual patient decisions, but also policy. So when we look at we've seen this over and over again, the chorea cascade, but then also when we're trying to build what we call natural history models, including precursor states for gastric cancer, we have other states, we have preclinical cancers, because if you impose screening, you might find it at this state. So every arrow and every state requires real human data to fit our models to. That's a lot of arrows, and as a math person, that's a lot of unknowns to solve for with not enough equations. So there's going to be a lot of uncertainty when we build those models. So I'm going in the other direction. Instead of going more transparent. Hey, Rob, I have extra 10 minutes because we're ahead of schedule, so pick up the clock. So we build multi-birth cohort models where we simulate the entire U.S. population, starting from patients born or individuals born in 1900, and then we try to fully leverage SEER data, which is representative of the U.S. population. Why do we do that? It's to also capture trends, both period and cohort effects, as we try to make estimates of interventions and the impact on the U.S. population. So this is one example. Is Summer here?
Summer was here yesterday.
Summer is here yesterday. So Summer is the biostatistician for the Stanford PO1, but she also is an active leader in the lung cancer group. And she was telling me yesterday that there was a large lung cancer clinical trial, NLST study, very large study, funded by the NIH with over 100,000 patients that documented the benefit of low-dose CT to reduce lung cancer mortality. Now, she said that they modeled 600 different strategies on top of that trial because it was completely based on pack years, but they wanted to know, for example, should the guidelines be different in Black men, for example? So there's a lot of, even if you have the definitive clinical trials, the implementation of actual real-life strategy probably needs modeling on top. Now, esophageal, so this example, this is esophageal adenocarcinoma. I used to lead that group. So once you get it, like once, should we do Barrett's surveillance at all? What interval? Then what about the surveillance if you have low grade, high grade, and you have multiple permutations such that we had almost 80 strategies that we analyzed. So there's no way you could do an RCT here. This is work that I've been doing with John and others in the room. Who else is there? Anyway, keep going. So I'm going to go quickly through this. So it started with the big four cancers, expanded to 2010 esophagus. John and I joined at that point, cervical cancer. And then in 2021, in the last iteration of U01 funding, the gastric cancer group was included. And I'll get back to this. I'm going to show you a picture. It's a very large group of people. And we're up for renewal soon. So I'm going to show you some examples of 3 different models for the esophageal adenocarcinoma group because we haven't made the pretty slides yet for the gastric cancer group. So this is the Hutch model in Seattle. This is the UW MISCAN, Ernst's old institution with Iris, and collaborating with John. John was at the UW back then. Now he's upgraded to Utah. Oh, excuse me. Sorry for the Seattle people. And I was at Mass General at the time. So we're trying to fit our model curves called calibration to real SEER data, so that anything that's bumpy is real SEER data. And then there are different ways to fit it. So for example, this is outdated, but the way we fit them, hit the targets, can be very different. And this has impact for what we think the projected outcome is. So this is just a visual analysis. So you could say, like, one group says there's going to be more esophageal cancer, one less, but that provides a range based on 3 models that are models, for example. But you can think about that and interpolate that to, like, for example, if we do an intervention, if we have 3 different results, we can come up with a range. Okay, so this is this is a large. Wow, it looks even bigger than when I first thought. So there's a lot of people involved. Let's see. Jen is one of the co-PIs. Where's Iris? Iris is leading the Erasmus group. That's me with the Columbia MSK group. There's Constanza. Constanza's everywhere. So, and Assad used to be part of it before. Anyway, so this is our group. Why do we need so many people? Because there's a lot of work to do. So we're in year 3. So this is the 4 goals that we proposed over 3 years ago. First is develop the simulation models. Like, so we had preliminary models, but we wanted to develop highly rigorous and reproducible models, and not just for the entire U.S., but by race and ethnicity. Particularly as we know in the U.S., gastric cancer is a disparity cancer, particularly impacting minority groups. So this is not surprisingly, taken a lot longer than we thought. The second, we wanted to assess the primary prevention. Now, there have been many studies based on HP, test and treat, but part of it was we wanted to incorporate more complexities and also do it by racial groups in the U.S. And then aim 3 is to develop secondary prevention, such as endoscopic screening and surveillance. And then aim 4, with Dr. Park, we wanted to make our models, simple versions of our models, to available to other nations through IARC if they were so inclined. So this is just the figure. So aim 1, develop simulation models and outcomes by race and ethnicity. So this has been, it's not surprising, but it's still surprising. Like Rob mentioned this before, but we've been working on this for 3 years, and the publications are finally coming out. So, for example, we heavily leverage SEER data, but we needed to get into minority groups because we wanted to build specific models for minority groups, and the numbers are small. For example, in Asian Americans, and it's hard to parse out. The histology, we've spent a lot of time. I think Costanza and others have connected us to pathologists in Australia and other countries, trying to parse out the coding. Rob's helped out with that a lot as well. And then even things like anatomical location, the importance of this, but to really try, as we build models that we're really trying to calibrate to, we're trying to get as accurate as possible and leverage it appropriately. The other thing is the precursor prevalence and transition rates. So Rob mentioned Monica and Han's paper, and this has been a huge collaborative effort. Rob led a Stanford team, including recruiting. Was she a med student or resident? So we were getting all this
now. Actually,
she's what?
She joined us on faculty. Yeah.
Fantastic. So she was, but this was the number of hours that went into this was quite a lot. So I'm not going to go into the details. I mean, Rob already mentioned some of the, because we just don't need overall prevalence of atrophic gastritis and intestinal metaplasia. We need it on multiple dimensions. We need it by age. We need it by even calendar year and by by race and ethnic group. And this is the complexity. So we tried to get as much data as possible so that we would make up as little data as possible. Okay, so this paper, I think, is in review. This is led by the Erasmus group. And then this is the paper that Rob mentioned. As we drilled down, we also made observations and contributed to the comprehensive literature reviews. So I think we went through this. No surprises, a lot of it. Significant differences, insignificant differences between asymptomatic and symptomatic. And this has big impact on the way we build and develop our models. And then no surprise, H. pylori is the largest variability in terms of the precursor, and the lack of data in terms of endoscopic reporting. So we've completed that, and so now we're moving on to assessing the primary prevention strategies such as HP test and treat, as well as smoking. This gets complicated because there are numerous analyses that have studied this, but we're trying to do it in minorities and then also incorporate dynamic changes with time. So as we all know, there's a classic cohort effect, right? Older Americans had much higher rates and changes with time. So we're trying to develop something called a H. pylori history generator, where depending on who you are, your rates you can have an infection, go away, and theoretically come back. It also by race and ethnicity, and it also incorporates antibiotic resistance down the road. So this is something like that we call like a module that we use in all three of the models. Force of infection, and this is work done by led by Fernando. Fernando is here at Stanford. I don't think he's here. So this has been done. We're still building this up, and then now we're up to the stage where we do more rigorous, what's the word? Testing of the models to verify. It's not technically validation. We just want to see what the model does when we stress test it. So we're running these simulations, and that a lot of this was developed at Erasmus. It's called the MClear, where it's we run these simulations that are extreme. So for example, let's say that you can eradicate 100% of HP, and we do it at age 20. What's the impact on gastric cancer incidence? What if we did everyone at 65, and then different scenarios, and then we run our models to see. In some ways, it's an extensive and well-coordinated sensitivity analysis. So we're meeting in the NCI in 2 weeks. I think some of you will be there, and we're going to share our results. The 3 different models will do this independently, and then we share our results to try to figure out whether there are differences and whether the difference is real or a bug, et cetera. Okay. How am I doing on time? I only have 4.5 minutes. Okay, I'm going to move ahead. So we still have 2 more years to move ahead. This is the part that we're really excited about, that we can create emulators, model simplified versions where, for example, other nations, and we can take a lot of the natural history that we've learned from the US population and beyond and apply it to other countries. Okay, so one of the benefits of modeling is that it provides a platform to really study a disease from 10,000-foot view. So as we look ahead, the benefit of being able to use a simulated platform as well as do thought experiments. And I think it's a useful exercise to map out future gastric cancer early strategies on a public health level, as well as to inform the design of clinical trials. Like if there's 80 different potential strategies, if we can kind of winnow it down to a few strategies, for example, that might be useful for trial design. Okay, so this is, John is our second-year JEF fellow that works with us. This is something we haven't submitted, so don't look at it, and don't recuse yourself if you get asked to be a reviewer. So this is in line with a lot of what we've been hearing. We did a SEER Medicare analysis, and what we did was we found patients who had a colonoscopy who developed gastric cancer. And then we looked at patients who developed gastric cancer who did not have a prior colonoscopy. And so it's a thought experiment. What if at the time of colonoscopy, that patient had received an upper endoscopic screening? And as you see, that theoretically, and this is claims data and all the limitations and uncertainties and selection biases, et cetera, but we were able to see a benefit in survival as well as stage. So this is starting to get at the opportunistic upper endoscopy screening, let's say, at the time of colonoscopy. This is Chiyun. Chiyun's right there. So she's a junior faculty member at Sinai, soon to be. So this is related to intestinal metaplasia of the cardia of the stomach. So as we know, we always kind of just focus on the distal stomach or the non-cardia, but John and I started in Barrett's, and so a lot of this irregular Z line for the gastroenterologists in the room. What do we do with intestinal metaplasia that's found in an irregular Z line or the gastric cardia? And the answer is we don't know. There's no guidelines. We don't know the natural history. So what we did was, part of this is we did scenario analysis. What if we came up with 4 progression rates, one the lowest and the highest. And it turns out the highest progression rate is from a Chinese study. So at the conclusion, of course, is surveillance for gastric IM cost effective? And the answer, of course, is it depends. It depends on what the progression rate is. So, but this Chinese study where the overall incidence progression was 0.22, it was cost effective, and perhaps we should be more aggressive. Whereas if we find someone in the U.S., and I think this highlights that not all gastric IM is the same. The reason I highlight this also, this is a reframing, and I think we've touched on it, that cancer and early detection and intervention should not be done in silos, but thinking about in context of this, of the endoscopy, in this case, in the endoscopy, the confirmatory test. So when we do an endoscopy, we look at the esophagus, both for squamous, harder to see without Lugol's Lugol's iodine, as well as adenocarcinoma, as well as the stomach, both proximal and distal, as we know. And this is, so I think this is the future of gastric cancer, not especially with genetic testing and paneling. Like for example, we're all familiar that BRCA raises the risk of ovarian as well as breast, but other cancers. So for example, pancreatic cancer. So this is the future. So I think trying to just focus in on one cancer may have limitations. And I think particularly for many of us as endoscopists, that we should be thinking about esophagus and gastric together. And also the oncologists, they view esophageal adeno and proximal gastric cancer the same because it's treated the same, and epidemiologically has some similarities. Okay, so I'm going to move on in the last 26 seconds I have. Okay, Rob, you're putting in some more time. Thank you.
You're already in the negative right now.
Oh, that's negative? Okay. Actually,
Yeah.
okay, do you want me to stop?
No. Finish.
Okay, all right, this will be 5 minutes. So, liquid biopsy, blood tests, right? Andy showed some amazing work with the ORF1 and that movie alone. Now we know where the money from the SUC went to create Hollywood level productions. But liquid biopsy is hot, right? So this is from a group in Singapore, and I don't know if our speaker later will touch on this, but it's Mir, I don't know how you pronounce this. But anyway, they use 12 microRNA biomarkers, and you can do it in a blood draw, 5 mLs. And they are reporting 86% sensitivity and 89% specificity in average risk asymptomatic patients for gastric cancer. Most importantly, stage 1, so early. Like, who cares if you can detect a metastatic gastric cancer, right? So they're showing 87.5. This is a little confusing. Maybe we can get explained because the sensitivity is higher for stage 1. But this is pretty good. It was just FDA approved in August, so theoretically it's available. They say it costs $200 in Singapore. I'm not sure what it's costing in the US. But and then they make it simple: low, intermediate, and high risk. So, and then the follow-up confirmatory test is based on that rating. So why is liquid biopsy, the appeal of a blood test for cancer screening makes a lot of sense. People like that. They don't want to do a stool test, and they're scared of endoscopy. So that's the holy grail for cancer screening, right? If you can get a blood test with your serum cholesterol. So there are older protein-based markers, including pepsinogen, but then, we've learned a lot from PSA, and we over-screened. So there's a lot of blood tests. But part of the reason the multi-cancer early detection tests have exploded is because we started, in the pursuit of precision oncology, precision treatment, we started sequencing all these tumors. So what the companies realized is they had a whole bunch of plasma, and then they had sequenced the tumors. And this is next generation sequencing. The cost went down. And then the combination of AI, so a lot of this is training in case control design, where they have sequences, and then using AI to try to predict which ones have this specific type of cancer versus the control. So that's why there are so many different companies. This is just a short list. I think Gallery has a test for 50. Exact Sciences, they have 12, but they're working on it. Various different companies, and a lot of them I appreciated Andy with ORF1 that it was biologically based. This is black box AI fitting to this. So, but this is coming. In gastric cancer alone, whether it be specific single cancer tests or multi-cancer tests, most of these MCED platforms include gastric cancer. So my concern with this is there's a lot of unknowns, but the cart is pulling the horse here because the public really likes this. Patients love the concept of a blood test. Who doesn't want early detection? We have some concerns. Should we use it in average risk? A lot of this initially has been for cancer recurrence or MRD, minimal residual disease, and then, for example, in pancreatic cancer for survivors with recurrence, or maybe just high-risk groups. Or low-risk groups, early onset where perhaps endoscopy is too aggressive. How accurate do the tests have to be? Which cancers will there be mortality? Now, this is a really big deal. If we look for ovarian cancer and we have a positive, the problem is the confirmatory test is not very good. We have CA19-9 and transvaginal ultrasound. And this gets to the big issue of the disutility of false positives. Whereas in gastric cancer, colon cancer, and esophageal cancer, the confirmatory test is very good. So even if you have a false positive test, but then we say the endoscopy is negative, I think we can reassure that the level of certainty that it's a false positive. There's a lot of issues in terms of the implementation. Who orders them? Should insurance cover these tests? Especially the follow-ups. What's the appropriate follow-up for which clinician should be responsible? The PCPs have enough to do, and who's going to make these decisions? So part of this, I don't think I showed this, but there's a bipartisan, very rare in today's political scene, bill that has over 100 advocacy groups that as soon as any of these multi-cancer early detection tests become FDA approved, that Medicare reimburses them, Medicaid and Medicare reimburses them. We're just a little concerned about the disutility. And so the question is, we can have single cancer early detection tests, but a lot of this is there are multi-cancer early detection tests coming. And how will that impact? If you have a positive or you have a negative for gastric cancer, is that going to diminish the adherence to upper endoscopy? Well, my blood test is negative. I don't need an upper endoscopy. And in high-risk groups, there may be utility in low-risk groups where they may have been over screening with an upper endoscopy, so a negative test may serve some benefit. Yeah, this is the bill. I was asked by the NCI Designated Cancer Center to sign support for this bill, and I passed for now. And I'm going to end with, this is my daughter, who is a sophomore in college in the area, and we rode for Team Gastric Cancer a couple of years ago.